Hello, you're listening to the MiCare Championcast. I'm your host, Ciaramitaro of the Michigan Health and Hospital Association. Each month, we invite industry experts and thought leaders to discuss relevant healthcare issues. Join us as we explore key topics that affect Michigan hospitals, health systems, and the health of our communities. Hi, you're listening to the MiCare Championcast. Joining me today is Wright Lassiter III, who is President and CEO of Henry Ford Health. Wright oversees the $7 billion integrated health system comprised of 6 hospitals, a health plan, and a wide range of ambulatory, retail, and other health services. Henry Ford Health has more than 250 locations across Michigan and 33,000 employees. Lassiter joined Henry Ford Health in 2014 and assumed the role of President and CEO in 2016. He has a master's degree in healthcare administration and graduated number 1 in his class from Indiana University. Today, we're lucky enough to have him on the show to talk about the social determinants of health, which is an important continuation of our conversations around health equity. Wright, welcome to the show, and thank you so much for being here.
Lucy, it's great to be with you.
So before we jump into today's topic, do you mind, it's kind of a theme that we've been following for the last few years with our guests, can you give us an update on how things are going in terms of COVID at Henry Ford Health?
Yeah, so I would say that we're excited about the fact that there is a lull, and that we're hoping the lull is not just temporary, but becomes permanent. Currently we have less than 50 patients across our system, actually less than 40 patients across our system who are suffering from COVID-19 complications. And so the great news is it provides a bit of breathing room for our staff and physicians who have been working like soldiers on the front line for more than 2 years. And we're hopeful that no new variants will change that. So it's the news is good related to COVID-19 and inpatient hospitalization, use of ventilators, critical care, and the like. But I would just note for your listeners that anytime I talk about this, I like to say that while there's a calm currently, we still know that there is significant strife amongst the healthcare industry because our team members have suffered mightily, but they've also been heroic over the last 2 years. And so we're pleased about the lull in volume, but we also know that the gas tanks of our team members are extremely low given the heroic efforts that they've put in over the last 2 years.
Right. And what are some of the best ways we can support our healthcare workers? I think that's such an important question. And how can we support them and also prepare or, I guess, be ahead of any upcoming waves of COVID if there is a new variant, say?
Well, I'd start off with something that for maybe many of us, our mothers taught us when we were very young, say thank you, right? Continue to say thank you to every healthcare hero that you know in your family, in your neighborhood, at your church, in your social functions, at your kids' schools, wherever that may be. First I would just say tell people thank you because those 2 words go a long way. And while many people understand that the community is grateful to the healthcare sector for what we've done over the last couple of years, saying thank you never hurts. So I start off with that. Secondly, as a healthcare leader, I think that we have to acknowledge that our team members need more emotional support than they've ever needed. And not all of our team members are good at asking for help. And so we've got to be even more proactive to remove barriers, to remove stigma, to remove the hesitancy that exists in our entire society around behavioral health support, mental health support, psychological support. And so our organization, like I'm sure many, have doubled or tripled the amount of resources we put into employee assistance programs and counseling and support for our team members. And so that's really, really critical, and we need to continue to do that. I think we also need to encourage the folks in our communities and our families, et cetera, to not give up on healthcare. You hear about the Great Resignation, and you hear about many individuals who might have either just joined our field or have been in our field for decades who are now saying, maybe I don't want to do this anymore, or maybe this isn't what I thought it would be. And so I would continue to encourage people to take up healthcare, whether it's nursing, pharmacy, social work, physicians, et cetera. I would continue to encourage individuals to do that because the healthcare pipeline is not sufficient currently to deal with all the challenges that we have as a society. And so that's really, really critically important as well. And then the last thing I would just say is to offer a bit of patience and grace to our fellow human beings as we're all trying to recover from an extremely stressful 2+ years. And so those are my a few tidbits from me on that point.
Right. No, those are great tips, and be kind inside and outside of the hospital, right?
Yes.
Well, I'd also be remiss if I didn't mention the new name, Henry Ford Health, previously Henry Ford Health System. Can you share what kind of drove that rebrand?
So as it relates to Henry Ford Health, we've been talking for a number of years about a couple of points. First, how do we ensure that the brand of Henry Ford, which has been around for 100+ years, how do we ensure that that brand gets all of the equity, all of the recognition, all of the consumer preference that it possibly could get, number one. Number two, how do we ensure that we constantly keep a tight connection between the purpose of the organization, its mission and its vision and values, with the personal purpose of the 33,000+ individuals that come to work each day. And then lastly, particularly as it relates to the COVID-19 pandemic, we've been talking as a leadership team significantly about what are ways that we can try to infuse energy, passion, purpose back into both the workforce, who has been beleaguered as it relates to leaning into the pandemic and serving our community, as well as then make that connection with patients and other key stakeholders who are big fans of our organization, and frankly, maybe those who are not fans of our organization because they haven't utilized us, but we'd love for them to be fans of our organization.
Right.
And so, it was a conversation, frankly, that we've had off and on, actually for more than 3 years, but we really got focused about a little over a year ago around it's time for us to think about how do we modernize, contemporize, and sort of create this sense of energy. And so for a lot of folks, what I say is, it looks like if you're just thinking about marketing or branding or advertising, it looks like a relatively small change, a 4-word name down to a 3-word name, taking system off. But it's really much more about that. It's much more of emphasizing the partnership that's necessary to achieve health between an organization like ours that has a lot of brick and mortar and a lot of humanity and 2+ million people that we touch on an annual basis. So how do we do a better job of what our ultimate goal is, which is to support the creation and the sustenance of health in the communities we serve. Mm-hmm. And so we really believed, and we got a lot of consumer feedback on this, that the word system is this sort of formal, it creates this formality that's about brick and mortar, that's about a building, it's about 4 walls. And health is about so much more than that. I mean, we're having a conversation here today about social determinants of health, which is a really critical case in point, which is you don't solve issues of health equity, generally speaking, in 4 walls of a hospital. You solve it with community partnerships. You solve it in partnerships with individuals who are seeking to be their best self. And so the Henry Ford Health concept was an embodiment of that. And then it also was an opportunity for us to create energy between our caregivers, team members, and patients around this notion of we are Henry, I am Henry. And as we began, looking at various ways to sort of tell this story, that the five letters that make up the word Henry, for us, it's not about a person, right? People think, we're named after Henry Ford. And so people think, well, this is about that. It's really not about that person. It's about the spirit that we are as relentless advocates of making the impossible possible, right? And so we really believe that this journey, and I don't call it a campaign, I'll call it a journey. The Henry Ford Health journey is really about creating this connection to stories about stories of triumph, stories of perseverance, stories of cure. In some cases, stories that didn't end the way we all would like them to end, but there is a story to be written about that, right? About what came out of that process. And so for us, the change to Henry Ford Health is not just a marketing campaign or a branding campaign or an advertising campaign. It's really about creating an ethos that really gets to the heart of the values of our organization, what we stand for, and what we're trying to accomplish on behalf of the communities we serve.
Absolutely. Yeah. Well, congratulations to you. It sounds like you guys have a really strong and clear vision, and I can appreciate that from the communication standpoint. And I did see a lot of posts on social media, and it looks like people are really excited about the rebrand. And I think it just says a lot about Henry Ford Health, just the vision behind it and the values that you do carry. And that lends itself nicely to today's conversation of health equity, as you mentioned. And I think it's good if we just get started talking about what are the social determinants of health. In a previous episode, I spoke with Dr. Renee Kennedy of the Michigan Public Health Institute, and she described social determinants of health as where we live, learn, play, and pray. And I think work was in there as well. Can you take some time just to elaborate on what that means and why social determinants of health matter so much?
Yeah, and so I think that description that you just provided is very illustrative. I would probably describe it, somewhat similar and say, social determinants are the social conditions in which people live their lives that impact the health of the community that they exist in, and so it's things that you can see, like race and ethnicity, or things you can hear like language. It is socioeconomic status. It is education status. It's their ability to transport themselves or be transported from the places they need to go. It is, social determinants get into access to things that allow them to live their lives well, like healthy food, clean drinking water. And so when you think about social determinants, it really is, what are all those manifestations that serve your current condition in life, that have an impact on your ability either to live your best life in the healthiest way possible, or to have challenges to be able to live that best life, and challenges that may end up causing differences in the expression of chronic disease, for instance. So that's how I would sort of tackle what is social determinants.
Yeah, that background is really helpful. And I think one of the biggest takeaways we can gain from talking about the social determinants of health is that a person's health and life expectancy in our state and country is often determined by environmental factors. And in order for us to achieve better health outcomes across populations, we really have to take that into consideration.
Yeah, no, absolutely. And it is, frankly, the differences in social determinants that creates the issues that health systems, that public health departments, that other community partners deal with when you think about healthcare disparities. When you look at, before coming to Michigan, I lived in Northern California and led a public health system that served Oakland and surrounding areas. And I was fascinated shortly after my arrival to read a report that talked about the differences in health and life expectancy for folks who lived in flatlands versus the hills. And the hills were considered, the places of the affluent, and the flatlands were considered the places of vulnerable populations. And there were lots of reasons for that, but and we'll talk about some of those things here in Michigan. But it just really shocked me as a relative newcomer to that part of the country, for a public health department to say, you know what, if you live in the flatlands, you will live 25 years on average less than if you live in the hills. And you heard that sort of thought and you thought, well, wait a minute, that can't be true. And you see some of those stark differences, across our country, unfortunately. And so these differences in social determinants that that causes the kinds of really concerning disparities that we deal with, here in the state of Michigan, certainly in Detroit. If you think about Flint, with the challenges around just access to clean water for a period of time when those residents were dealing with water that was not healthy, and the decades of impact that will have, right? And so social determinants cross race, they cross class, they cross ethnicities, they will cross educational opportunities, et cetera. So.
Yeah, those are great examples, and I think people start to listen when you describe the social determinants of health as having an impact on their community, and hear compelling statistics like the fact that it affects infant mortality. I mean, when people hear that, they want to learn more and they want to talk about it. And I'm curious, what do we know about the social determinants of health in Michigan specifically?
Well, I think probably one of the best examples of what we know is something called the data that comes out in the United Way's ALICE report, right? And so the ALICE report, for those who aren't familiar with it, it stands for asset limited, income constrained, employed. And so it's a report that the United Way puts out on a regular basis to examine what is the prevalence in the state of Michigan of families who struggle to afford basic needs. Mm-hmm. And in one of their recent reports, their data suggested that almost 1.7 million households in Michigan, which they estimate to be about 40% of the population, couldn't afford the basic elements that household needed for success, such as food, housing, healthcare, childcare, transportation, and technology. And that report came out just before the first cases of COVID hit. I haven't seen the report since that time as of yet. I think the next report's coming out very shortly. And what you can imagine is that given both the health and economic challenges that the state of Michigan and the entire country faced during this global pandemic, you would expect that number, frankly, to be worse. Mm-hmm. And as you think about the great resignation and people leaving, quote unquote, leaving jobs, either because the job no longer existed or because they changed lifestyle, you would imagine that continues. As you think about the current rise in inflation that's hitting the entire country, states like Michigan that have 43% in that study of its households being income constrained and not able to meet its basic household needs, you can only imagine that those numbers have likely risen. Mm-hmm. And when you think about the disparate impact that COVID has had on particularly communities of color in the state of Michigan, but not just in the state of Michigan, you would imagine that in vulnerable populations, those statistics are frankly even more glaring.
Yeah, the pandemic has definitely amplified that and I think brought the conversation of health equity to the forefront.
Right.
So
right.
As the president and CEO of a major health system, how would you say the social determinants of health impact the way Henry Ford Health delivers care?
One of the things that I'm proud of, and this began long before I arrived here to lead our organization, we've had a penchant for serving the safety net and serving populations that were vulnerable. Mm-hmm. And while we have facilities in multiple parts of the communities that we serve, many of our assets are concentrated in urban communities and communities of vulnerable populations. And so, we honestly, one of the things that in an interesting conversation I've had with team members at times, I've said, if we really don't want to focus on issues of health equity and disparities, then we should move all of our assets to different parts of the state because we have no choice. If that wasn't our mission and vision, we'd have to move our assets. Right. And so our mission and vision certainly is to serve. But I would sort of start off by saying that some of the most vexing issues that we face in our communities are one issue that you mentioned earlier, maternal and infant mortality. Mm-hmm. blood pressure control in vulnerable populations, the need for comprehensive diabetes care because of the prevalence of diabetes in so many of the populations that we serve, and frankly, a significant use of emergency services because the primary care fabric isn't deep or wide enough for many parts of the community that we serve. And so when you ask the question, so how does it impact us? I would say, pretty dramatically. We acknowledge that if we don't think about health equity, if we don't think about meeting people where they are when they either seek services for us or as we assess community and try to reach out to the community, if we're not looking at that from a lens of social determinants and health equity, frankly, we'll do a disservice. One of the big challenges when you think about serving vulnerable populations and populations that have significant needs is that you have to really understand what the needs are.
Right.
And if we approach every person as if their needs are somewhat homogenous, what ends up happening is, for that small population that your set of interventions are perfectly matched for, they will get what they need.
Right.
But for everyone else, we will not meet their needs. And so whatever challenge we're trying to help them overcome, we likely will be ineffective because our interventions aren't tailored to the specific sets of needs that they bring forward. And so for us, we spend a lot of time trying to understand what are the specific needs, what makes that person unique, what's their unique set of circumstances that then might cause us to need to respond in a way that's tailored to that population. And I think for a long time, and one of the things that has me excited about this, sort of increased fervor across the nation around health equity and disparities, is that what it's really helping people acknowledge is that it's not that we necessarily were doing something wrong, it's just that we were functioning in a vacuum. We didn't fully understand. And frankly, in almost every other sector outside of healthcare, people that deliver products and services understand their consumers extremely well. They understand their buying habits. They understand their household needs. They understand so much about their consumer that they're tailoring their product or their service, in our case, intervention, but in their case, a product or service to what's going to meet the need for that individual. And historically in healthcare, we've just not done that. We've not been that sophisticated. We've had a big heart and we've had a lot of energy and we've put a lot of that heart and energy toward doing a thing. And oftentimes we sort of presume that, like if you're out in a farm, like every cow's brown or every cow's black or whatever, and doesn't have any unique needs. And honestly, for people that have kids, what I always say is, it's sort of like if you have multiple kids in your household, they have different needs. And so they need different things from their parents. And if you parent all 4 kids, if you have 4 kids the same exact way, unfortunately, your 4 kids likely might not be their best selves because they need something different.
Right.
Some kids need tough love. Some kids just need a pat on the back. Some kids need a hug. Some kids need space. And if the kid that needs space gets a hug all the time, they're likely not going to be their best self. If the kid who really needs a kick and some tough love only gets a hug, they're probably going to underachieve, right? And so it's that sort of setting in healthcare.
Yeah, that's a great example, a way to compare it. And you brought up fervor, and I think people entering, the positive of this is that people entering the healthcare workforce are hearing these conversations. And I think especially younger generations are really eager to make change and be a part of addressing health inequities. So I'm curious what your advice would be to those in our hospitals and health systems, maybe those that are just entering, who want to be more conscious and intentional about how they provide care to patients.
Yeah, so I would start off with, I would love to say every healthcare organization, and I hope the answer is every, but I'll say most, are really focused on trying to provide their caregivers and team members with tools that they need to do this better. And I would just say that you start off with cultural competence training, right? Just being able to understand. And so it doesn't mean that we all get brought up and get trained with our own set of of understanding about our fellow human beings. And the reality is, without specific cultural competence training, we all are ineffective at understanding the needs of broader populations, particularly those that we have less familiarity with. And so I would really start off with, it's really important to get cultural competence training, however your organization provides that. And my hope is that your organization provides it. And if someone's listening to this when this airs, and if the organization doesn't provide it, maybe you should find an organization that does provide cultural competence training, because that gives you a sense that that organization is more serious about trying to equip their team members with the tools they need. Secondly, I would say beyond cultural competence, unconscious bias training. So I was exposed to the concept of unconscious bias a few years ago, and if the more you read and understand about it, it just, again, helps us all acknowledge that, none of us as human beings are perfect. And at times, even with the best intentioned individuals, we may hold biases that aren't on the surface that impact our ability to do the best job on behalf of others.
Right.
And so a combination of sort of the traditional cultural competence training and unconscious bias training, in my mind, are two amazing toolkits that would allow most team members to be their best self, and not only be their best self, but then to really be able to understand others in a way that allows us to help intervene in whatever way we are providing care or service, et cetera. And then maybe the last thing I would say about what team members in the healthcare space should do is look at the data. As I mentioned previously about other industries and how well they know their consumers or their targets, right, their customers. Historically, we haven't had that granular of data, and so some of the most humbling times for me in this long journey that I've been on with two organizations in particular throughout the last almost 20 years of my career, as we've gotten very serious about healthcare disparities and health equity. What I've really learned is that oftentimes we believe we're doing our best job until we begin to segregate the data in a way that helps us understand the unique characteristics of populations we serve. And then we begin to sort of say, hey, we have been taking sort of this cookie cutter approach and sort of presuming that the four children all have the same needs when they don't. And so I think that ask for data that it really allows you to sort of understand. If you're working in an emergency department, are there differences in outcomes based upon race, ethnicity, language, gender, or based upon other characteristics, whatever might be unique and special to the population you serve. And so, everything is not always about race. Everything's not always about ethnicity. Sometimes it's about language. Sometimes it's about other cultural tenets. Sometimes it's about things that are not related to any one of those. But if you never segregate the data in a way that allows you to say, okay, here are the unique characteristics of population X, and as a result of those unique characteristics, our intervention really ought to be Y. And so, I think in most cases we have all the intervention sets that we need. Oftentimes the problem is we're applying the wrong tool to the problem, right? The wrong solution to the problem set. And so when we better understand the problem set, we generally have solutions to solve it. Now, then the bigger question sometimes is, well, there's too many problems to solve, and sort of like world peace or world hunger, you can't solve them all. And so sometimes the biggest challenge we face is not what's the solution or even how to apply it. It is, but we've got so many problems. Which ones are we going to focus on? Because you can't focus on everything, right? So
that reminds me of a point Dr. Kennedy brought up, and that is with health equity. It can't just be a one-size-fits-all approach. It's not enough just to know the social determinants of health. You have to really examine your specific patient populations and determine an approach and processes that cater to those patients. And on the other side of the coin, I'm curious what advice you would give to a patient to better advocate for themselves, knowing the social determinants of health and their external environment that may influence how they deliver, or they receive and need care.
Yeah, so the first thing that I would say, Uzi, is I think it's really important for patients to understand that they are in control. They're in control of their health care, which means that that if you're in control, you have to advocate and communicate as effectively as you can. And, at times there's certainly I understand the barriers to to communication in different cultures, different age groups. But it's really important for patients to really acknowledge that they're in control. And so that means that they have to tell the providers that they're encountering what's going on, what's working, what's not working. And sometimes that doesn't fully happen. They have to make sure that they let the care team know when they believe their needs are not being met and why, so the team can attempt to address the concern. And then I think that it's important, the white coat syndrome is a important bond that has lasted in our country for a long time. And that's the bond, the connection between an individual patient and their physician. And for a long time, the view was, whatever the physician said, was right. Whatever the physician said, I do. And sometimes you need to say to that individual, I don't feel like I'm being heard, or I don't feel like my needs are being met. And ultimately, if you really get to a place where you don't think that that's happening, then you should change your provider to someone who you believe understands you better and is able to reflect and respond to your unique needs. And then I would just say to the listeners, we have room at Henry Ford Health. And so if you believe that your provider isn't meeting those needs, I'm sure we can find you a provider in our system who will do that and hopefully do that to your expectations and beyond.
Right. Absolutely. Well, that was a great answer. And we appreciate you so much for being on the podcast today. You provided some really valuable insight on a very important topic that we hope to continue exploring. So thank you for being here.
Thanks, Lucy. It's my pleasure.
Thanks for listening to the MiCare Champion Cast. To learn more or get involved, visit MiCareMatters.org. That's MiCareMatters.org.